Welcome back. Chapter 10 turns to a dimension of whole person healthcare that is easy to overlook in a clinical or biomedical framework, but that shapes patient experience profoundly: religion and spirituality. I want to name something at the outset. This chapter isn't asking you to adopt or evaluate any particular religious or spiritual belief. It's asking you, as a future communicator, clinician, or health professional, to understand religion and spirituality as significant pattern dimensions of how real patients make meaning of illness, healing, and care, and to build the communication skills to engage that dimension respectfully, regardless of your own personal beliefs or lack thereof. For my nursing and health sciences students, this connects directly to palliative care, hospice, and chaplaincy services you may already be encountering clinically. For my communication students, this is a rich site for studying disclosure, privacy boundaries, and meaning making, as communication in some of the highest stakes conversations occur in healthcare in this realm. Let's preview the first half of today's 11 learning objectives. Articulate how religion and spirituality are similar and distinct conceptually, and specifically in relationship to the goals of medicine. Identify the diversity of traditions that have shaped the medical religious partnership from ancient times through the present. Apply culturally sensitive healthcare principles for individuals from all religious and spiritual backgrounds. Provide ethically grounded recommendations for integrating religion and spirituality in healthcare settings. Identify challenges of integrating religion and spirituality in palliative care, hospice care, end-of-life care, and chronic care self-management. And the second half of today's objectives include: provide recommendations for accommodating diverse religious affiliations, understand medico-religious partnerships and professions in value-based care, quality of life, and social support through communities of faith. Understand religion and spirituality in compassionate, just, and transformative care, and through professional training such as clinical pastoral education. Explain the relationship of religion, spirituality, and health behaviors in organizational and healthcare institutional settings. Situate religion and spirituality in patient-centered care for religious minority and vulnerable populations. Apply models for integrating spirituality into medicine through inclusive and culturally sensitive communicative practices. So let's dive in. Let's start by carefully distinguishing our two central terms, because they're often used interchangeably in everyday conversations. But in our chapter and course, we treat them as related, overlapping, yet genuinely distinct concepts. Koenig defines religion as a system of beliefs and practices observed by a community, supported by rituals that acknowledge, worship, communicate with, or approach the sacred, the divine, God in Western cultures, or ultimate truth, reality, or nirvana in Eastern cultures. Puchilasky and colleagues define spirituality as the way individuals seek and express meaning and purpose, and experience connectedness to self, others, and the significant or sacred. How do we tell apart these two concepts in practice? People who describe themselves as spiritual may not necessarily see themselves as religious. Spirituality tends to be referenced in connection with a source larger than oneself and with feelings of transcendence, while religion tends to be referenced through concrete practices such as religious affiliation and service attendance. Now, this distinction matters clinically. A patient can be highly spiritual without practicing any organized religion, and a patient can maintain religious affiliation and practice without necessarily describing a strong sense of spiritual transcendence. Providers who conflate the two risk missing a patient's actual meaning-making resources. And as we know, meaning-making is at the heart of communication. In this chapter, we break religion and spirituality down into 4 different dimensions. This framework is useful because it lets us talk concretely about how religion and spirituality show up in a patient's life, rather than treating it as one undifferentiated variable. So we have first the affective dimension, the subjective emotional experience of religion and spirituality. A sense of transcendence, meaning, purpose, and connection to a source larger than oneself, as well as struggling with or feeling anger towards God, all come under this dimension. The behavioral dimension, the use of religious or spiritual practices to manage stress and life events, such as those related to cancer and its treatment, including meditation, prayer, pursuing a connection with God, attending religious services, and strengthening connections with religious people, activities, or groups. Third, cognitive dimension, statements and individual beliefs to be true about religion and spirituality, such as causal attributions, spiritual post-traumatic growth, religious fatalism, and intrinsic religious or spiritual beliefs. Fourth, physical dimension. This includes physical well-being or the ability to perform activities of daily living, from basic self-care to more strenuous activity, functional well-being, perceived difficulties fulfilling roles at home, work, or in the community due to physical health, and third, self-reported physical symptoms such as fatigue, pain, sleep difficulty, and cognitive symptoms. Take a minute to notice how the physical dimension may seem at first glance unrelated to religion. But in this chapter, we are making a deliberate claim. We are saying that religious and spiritual coping is entangled with physical functioning and symptom experience, not separate from it. Let's now look at how religion and spirituality function within healthcare contexts and meaning making around illness. Religion, spirituality, and health meaning making shape health behaviors in fundamental ways. A well documented example includes, let me tell you how. Spirituality and social support have been important in the coping experiences of people living with HIV and AIDS, where stigma and identity are especially fraught. So, in this example, understanding communication within religious groups also helps illustrate a group's shared self concept regarding health. In this case, how a faith community collectively narrates illness, healing, and bodily care. Religion and spirituality also play a role in health related disclosures, both in interpersonal contexts, such as with a partner, and in clinical contexts, such as with a provider. And religion and spirituality can support self-efficacy in patients managing chronic conditions or other conditions requiring ongoing self-management. Religious affiliations reflect a genuine diversity of values, drawing on a wide range of cultural beliefs. Gender norms, nutrition practices, and prayer all influence a patient's expectations of care and their own ethics of what it means to be well. Healthcare provider training in cultural sensitivity directly informs the quality of care given to minority populations, and culturally sensitive care is associated with measurably better health outcomes. Let's take a brief historical detour. Ancient cultures interwove the goals of health and healing directly with faith and spirituality. Healer and priest were often the same figure, or closely allied roles. The traditions of medicine and religion formally separated during the Age of Enlightenment, as medicine moved toward an empirical, secular, scientific model. This chapter, in a sense, is asking us to reconsider what was lost and what might be reintegrated thoughtfully in that historical separation. In present day clinical settings, religion and spirituality contribute to building a trusting and open healthcare relationship. Religious coping, decision making, and spiritual well being have been shown to help promote patient self efficacy. Let's move into some of the highest stakes applications of this material. Palliative care, defined as care given to people living with a serious illness. Religion and spirituality help with sense making at exactly the intersection this course keeps returning to: what it means to live a purposeful and meaningful life, even amid serious illness. In end of life decision making specifically, understanding the intersection of health, religion, and spirituality is valuable for structuring communication in final messages with the terminally ill and can support provider patient communication during final conversations. Research on final conversation messages, notably by Keeley, has identified what the chapter calls 3 rules of conduct that tend to organize these conversations, patterns in how people navigate coping with life challenges after the death of a loved one, being actively involved in the death and dying process itself, and enacting religion and spirituality during death and dying. This same integration of religion and spirituality is also a valuable resource in chronic conditions, informing meaning making and culturally sensitive care, and directly informing the design of health promotion messages and health education programs for patients managing long term illness. Pastors and communities of support share a common bond of trust with patients and congregations. Religious beliefs and practices help people cope with stressful life circumstances, give meaning and hope, and surround people experiencing depression with a supportive community. This connects to what the chapter calls compassionate, just, and transformative whole person health care, based on the assumption that whole person health care is a human right rather than a privilege. The Association for Clinical Pastoral Education, ACPE, is recognized by the U.S. Department of Education for setting standards for spiritual care and education. CPE, which is Clinical Pastoral Education, brings pastoral care directly into clinical settings, helping with the understanding of suffering and the re-examination of a patient's lifestyle, existing goals, and priorities. Johns Hopkins Medicine describes this work as attending to the spiritual needs and resources of each individual, participating in the comforting and loving activity of God in order to promote the restoration of health and wholeness. During times of great stress, many patients and their caregivers look towards whole person healthcare providers in hopes of a medical miracle. CPE trained chaplains are specifically equipped to help respond to these conversations that a clinician alone may not feel equipped to navigate. Finally, this work requires constructing religious and spiritual privacy boundaries for religious disclosure requests. Patients and families don't uniformly want the same level or type of religious engagement from their care team, and respecting that variation is itself part of culturally sensitive care. Let's now get concrete about specific healthcare contexts where religious and spiritual diversity has direct practical implications for care delivery. Providing religious and spiritually appropriate care means being inclusive of all patients' needs and the full diversity of their beliefs. Let's walk through the specific contexts where this shows up in practice. Prayer times, accommodating scheduled prayer within a care routine. Medicines based on animal products or that contain caffeine or alcohol, which may conflict with the patient's dietary or religious restrictions. Diet and nutrition more broadly, modesty, preferred gender of providers, medical procedures, including the meaning and importance of bodily integrity in procedures such as surgery or vaccination, faith, healing, and prayer, alternative therapies. Notice how many of these, modesty, gender of provider, medication ingredients, are easy for a care team to overlook entirely unless they are actively asked about, which is exactly why proactive, routine inquiry matters more than waiting for a patient to raise a concern. one more specific context: the provision of neutral prayer space within a healthcare facility, space that doesn't privilege one faith tradition's iconography or symbols over another's. Your course materials include an attached form addressing the question: how can healthcare providers be sensitive to religious and spiritual considerations? You can always view that. It's attached under this lecture. The link for this YouTube is also uploaded under this lecture on Canvas. It's called Cultural and Spiritual Sensitivity in Healthcare. As you watch, think critically about how you would advise healthcare providers to communicate in a culturally sensitive, patient-centered manner about a patient's cultural or spiritual practices and approach within the healthcare setting. Let's close out this topic and our final chapter for the course by looking at religion and spirituality's role in shaping everyday health behaviors, particularly around chronic condition self-management. Chronic condition self-management happens at the day-to-day level, and it's an increasingly central concern given our aging population and what we've called in the chapter a broader chronic condition epidemic. There's a real connection between preventive care and faith. Religious and spiritual care can support health literacy at the community level, touching medication management, lifestyle changes, sustaining preventive behaviors, and health monitoring. Local religious organizations and health education programs are a significant, sometimes underused channel here. Medico-religious partnerships can provide patient-centered whole-person healthcare that is especially valuable during health crises, and faith leaders often function as opinion leaders, promoting health promotion, risk reduction, and disease prevention behaviors within their own communities, often with a degree of trust that outside health messaging cannot easily replicate. That said, real gaps remain in furthering the spiritual health identity connection. Aligning religious beliefs and workplace practices is fraught at many levels, and there are ongoing gaps in how terms like religion, spirituality, and faith-based health support are understood, practiced, and shown to actually shape health outcomes across different studies and settings. All of this ultimately comes back to patient-centered care as the organizing principle. Patient-centered care is associated with a concern to provide care in a manner that is authentic and meaningful to patients. Patients from different religious backgrounds have varying expectations of what constitutes ethical and appropriate care, and these concerns are particularly impactful for minorities and those in vulnerable religious and spiritual communities of faith, who may already anticipate that their needs will be overlooked. So how do we actually provide culturally sensitive, value-driven, religious and spiritual whole-person health care? A few concrete strategies. Bridging the gap with spirituality and religion by understanding how spirituality guides a patient's quality of life and medical decision making. Training and socialization of clinicians in spiritual care, so that this isn't left to chance or individual clinician comfort level. Establishing clear standards of spiritual care provisions within an institution. Understanding a patient's illness context as a genuine hybrid of secular, sacred, and humanistic elements, not one framework to the exclusion of the others. This final point is a good place to summarize this entire chapter. Illness for many patients is never purely biomedical, purely spiritual, or purely a matter of personal meaning making alone. Whole person healthcare asks us to hold all three together. We've covered a lot today. We started from the conceptual distinction between religion and spirituality, the four dimensions of religion and spirituality, the historical medico-religious partnership, palliative and end-of-life care, clinical pastoral education, and the concrete healthcare contexts where religious and spiritual diversity shows up in practice. As you go towards this week's engagement and advocacy application activities in the lab section and complete the reading review, try to think about your key takeaway from today's discussion on Chapter 10, Religion and Health, specifically regarding how religion and spirituality, viewed from a whole person healthcare and social justice activism perspective, can support inclusivity, access, and equity in health. How will you engage that takeaway in your own community? As you leave this chapter, think through some of the key threads we've talked about. Can you distinguish religion from spirituality and give an example of a patient who might identify as spiritual but not religious? Can you name the four dimensions of religion and spirituality that we have covered in this chapter and what they mean, such as affective, behavioral, cognitive, and physical? And can you give one example, behavior, or belief for each? Can you think about what clinical pastoral education is and what role can clinical pastoral education trained chaplains play in conversations about medical miracles or hopes for a cure? Can you name at least 3 healthcare contexts where religious or spiritual diversity has direct practical implications for care? For example, prayer times, medication ingredients, modesty, or the gender of the provider. Can you think about why the chapter describes a patient's illness context as a hybrid of secular, sacred, and humanistic elements? And why does that matter for patient-centered care? As the last chapter of the semester, and this was our summer semester, so we packed a lot in a very short time, try to tie this in right from our first chapter on whole person health communication through the principles of social justice and activism, through the models of health and medicine, and the different contexts that we've looked at, from healthcare relationships to literacy to technology, environment, and religion, and see how patient-centered care communication, and a social justice perspective can help us achieve the goal of flourishing and better health for all. Thank you for staying through all these lectures, and I'm looking forward to reading your engagement and advocacy application activity notes. These are always fun to read, and your reading review thoughts, again very fun to read, and your final case studies.